Assalamu alaikum wa rahmatullahi wa barakatuh. The case of today teaches us how to organize our informations along with the available clinical data in order to reach a definite diagnosis, or at least limit the list of the differential diagnosis as much as we can. The case for an Indian male patient, 35 years old, complaining of cough, fever, convulsions, headache, as well as back pain. The physician requested plain X-ray chest, CT chest abdomen with intravenous contrast, as well as MRI brain with intravenous contrast. Starting with the chest X-ray. This is chest X-ray showing miliary shadowing or micronodular infiltration diffusely involving both lung fields, as you see here. The CT chest confirming the diagnosis of miliary shadowing or diffuse micronodular infiltration of both lung fields, as you see. Regarding the abdominal study, regarding the solid abdominal organs, unremarkable, but the finding here, we have destructive end plates here in the lower thoracic vertebrae, as well as adjacent paraspinal fluid collection. As you see, destruction of the end plates with paraspinal fluid collection in more than one level, in the lower thoracic level and in the upper lumbar, as well as in the lower lumbar level. So we have multiple levels of end plates destructive lesions, and in the uppercut at the thoracic spine, it's associated with paraspinal fluid collection. MRI study of the brain regarding FLAIR study showing multiple lesions with low signal intensity, as you see here. Hyper-intense REM with low signal intensity seen here in the right temporal lobe. And also in the T2, the same appearance, hyper-intense ring with low central intensity. We can appreciate one here in the thalamus and the left thalamus. And another one in the hippocampal area in the right side of the temporal lobe. Also in the brainstem, also here we can appreciate another lesions. But in the post-contrast study, we have innumerable lesions. Most of them were not appreciated in the pre-contrast study. The lesions, as you see, ring-enhancing lesions with low central intensity involving both cerebral hemispheres, the brainstem, as well as involving the both cerebellar hemispheres. Now, let us summarize our findings as well as the different radiological signs in addition to the clinical data in order to reach a diagnosis, as I told you, or at least limit the differential diagnosis. Starting with plain X-ray chest and CT chest. What do we have? We have miliary shadowing or diffuse micronodular infiltration of both lung fields. Micronodules means nodules less than 3 millimeter. Here we have 8 differential diagnoses for the miliary shadowing on the lung. 5 of them not associated with fever, and 3 differential diagnoses associated with fever. The 5 differential diagnoses of miliary shadowing not associated with fever are sarcoidosis, pneumoconiosis, alveolar microlithiasis, Langerhans cell histiocytosis, as well as metastasis from highly vascular tumor, where the 3 differential diagnoses of miliary shadowing of the lung but associated with fever are tuberculosis, histoplasmosis, as well as varicella zoster pneumonia or chickenpox. The findings in MRI brain, we have innumerable lesions of ring enhancement with central low intensity. These lesions in T2 and in the FLAIR giving low central hypointensity. The differential diagnosis of multiple ring enhancing lesions in the brain are metastasis, brain abscesses, toxoplasmosis, neurocysticercosis, tuberculoma, as well as sarcoidosis. But the presence of central low intensity in T2 and in the FLAIR images raising the possibility of tuberculoma, because the other differential giving high signal intensity in T2 and in the FLAIR. While the CT features of destructive end plates associated with paraspinal abscess collection, this is a pathognomonic features of what is known as POTS disease of the spine or tuberculous spondylitis. So, regarding the radiological signs of miliary shadowing in the lung, POTS disease of the spine, granuloma of the brain with low central intensity in T2 and in the FLAIR, in addition to clinical data of fever, and the Indian nationality of the patient as TB is endemic in this area. All of these radiological features are highly specific for the diagnosis of tuberculosis. In summary, tuberculosis can affect many internal organs at the same time. It has what is known as pathognomonic features radiologically, as spots disease of the spine in the form of destructive endoplates with adjacent paraspinal abscess formation. In the brain, by the MRI, diagnosis of tuberculoma with characteristic low signal intensity in T2 and in the flare. In the lung, by CT chest, it gave the characteristic appearance of miliary shadowing in addition to another pattern which is considered very pathognomonic for diagnosis of tuberculosis, which is known as tree-bud pattern, which describes the CT appearance of multiple centrilobular nodules with a linear branching pattern resembling a budding tree, which represent transbronchial spread of tuberculosis. In the abdomen, tuberculosis can give the appearance of omental cake, which refers to infiltration of the omental fat by material of soft tissue density. Omental cake limit the differential diagnosis into 3 diseases: tuberculosis, lymphoma, as well as peritoneal deposits. Also for tuberculosis, when involving the lymph nodes, it gave a characteristic pattern of central necrosis, regardless the location of the lymph nodes. As you see in these examples, necrotic lymph node from tuberculous infection in the neck. This is tuberculosis of lymph nodes in the mediastinum, and this is an example for tuberculous lymphadenitis in the abdomen by CT scan. So these are the different radiological signs which you consider to be characteristic or even pathognomonic for the diagnosis of tuberculosis. See you, inshallah, in the next episode.